Afternoon, I'm Dr. Charles Bailey. I'm a vascular surgeon at Emory University in Atlanta and director of our limb preservation and peripheral arterial disease program. Well, I'm very happy and excited to talk about Penumbra's THRIVE study today, which we'll be presenting here at the Vascular Annual Meeting. When it comes to treatment of acute limb ischemia, a lot of people have been slow to accept or adopt the endovascular first approach. And so the study with Penumbra here is a real ingenious way to prove that a computer-aided vacuum thrombectomy Penumbra first approach is very favorable as compared to traditional surgical therapies. So the THRIVE study was a retrospective look using the Vizient clinical database at the outcomes, both clinical and healthcare resource utilization, comparing endovascular first using the Penumbra CAVT therapy versus surgical embolectomy and surgical embolectomy with other adjunctive procedures. What the THRIVE study sought to examine was the differences in both clinical outcomes and healthcare resource utilization between these three therapies. And in very evenly matched cohorts, they examined both hospital length of stay, ICU requirements, adverse events, readmission rates, and major kind of limb-directed adverse events and resource utilizations. And some of the key notable findings is in comparing these three therapies, the CAVT Penumbra therapy using the Lightning 7 and 12 systems showed, as compared to the two surgical cohorts, lower rates of major limb amputation, lower rates of both total length of stay and post-procedure length of stay in the hospital, lower rates of individual organ system and composite adverse events post-procedure, lower rates of both acute limb ischemia and all-cause related readmission, and most importantly, a much greater likelihood that the CAVT patients would be discharged simply to home without requirement for other healthcare related resources. If we have a therapy that can offer a patient a shorter length of stay, a greater likelihood that they're going to go home, and associated with it not only good clinical and proven clinical outcomes, but a greater freedom from adverse events, greater freedom from complications or potential readmission, we should embrace that therapy. So I've been practicing with a CAVT first approach for quite some time, and I think for others who may be undecided or on the fence, this is really compelling evidence that this is the right therapy for our patients. Medicine as a whole, all specialties, we're definitely in this area where cost matters and the cost of care for a patient matters, and I foresee a day where we might be judged and graded based on our ability to deliver efficient health care. When you look at the THRIVE study and some of the key outcomes, including significantly lower rates of major limb amputation for CAVT as compared to the surgical arms, yeah, there's a significant cost to that. Well over $100,000 added to a patient's care, and multiples of that when they require major limb amputation. And I know in the states I've practiced, in Florida and Georgia, some of the biggest challenges we have are getting our patients not home, but to rehab facilities or to other facilities to continue their care. And our study showed that with CAVT, you're much more likely to go home. So there's a cost to the patient, a cost to the healthcare system that's improved upon with the CAVT approach. I hope with the THRIVE data that providers and those that care for acute limb are a little more thoughtful in the therapies that they consider in treating the patients. And our goal as physicians is to provide the best possible outcome for our patients. And the THRIVE data shows that a CAVT first approach does lend itself to better outcomes as compared to traditional surgical therapies.